Okay, well, thank you, Seth. And it's very nice to be here. This is a great turnout, actually. So this is really, really terrific to see everyone here. Now, I am a medical oncologist. So you might ask, what am I doing here? Well, my interest is in prevention of cancer and early detection. It turns out, as you've heard, that colon cancer is very preventable. Not always, but often a preventable death. So we've learned a great deal now about how to assess risk, how to figure out who's at risk, what their level of risk is, and how we can help protect them and prevent the cancer or the death. Okay, this is my one and only quiz question for you, okay? If you have a patient, if you yourself are in the United States and you have a history of colorectal cancer, what do you think the incidence is that that person with colorectal cancer will have a family history of colorectal cancer? Do I have to push something here? Just, okay. There you go. 30 seconds seems like a lot, right? Huh? I can keep advancing it? Okay, here we go. Quick. Oh, it came up. All right. All right, well, look at that. 34% of you said 25%, right? Very good. So I think you learned something from Seth's discussion. That's excellent. That's right. 25% of patients who have colorectal cancer have a family history of cancer, and only a family history. Another at least 10% of patients have a genetic syndrome or hereditary cancer syndrome that puts them at quite a high risk, significantly high risk for cancer. So that's important to be aware of and to identify that population. I listed for you on the bottom some of the genetic syndromes that we know are associated with a very high risk of developing colorectal cancer. And we're going to talk about that a little so you can figure out whether you're likely to be in that group, because that group has to have special attention and good treatment. Lynch syndrome, the polyposis, the familial polyposis syndromes, something called Putz-Jaeger or Bloom syndrome. This is a very burgeoning field, cancer genetics. It's evolving basically daily as we speak. And I can tell you that within the next few years, we will have enormous power to detect cancers genetically and treat them, prognostic, predictive, and treatment related to understanding the genetics of cancer. We're really balanced on the edge now of a huge breakthrough in cancer treatment and therapy. Now, for prevention and screening, the approach that usually works best is a collaborative approach between the patient and the doctor. So when you go to your doctor, bring as much information as you can about your family history, any genetics that you know about, associated medical diseases. Your personal medical history is tremendously important. Obviously, exposure to carcinogens, but things that you might not naturally and normally think are related to your risk of colon cancer, like a skin condition, a thyroid condition, a kidney condition. Those things can actually be a tip-off to your doctor about a significant risk of colon cancer, colon or colorectal cancer. So bring that information, tell your doctor, and then every patient needs a thorough review with their doctor of lifestyle issues, diet, body mass index, exercise, cigarettes, and alcohol, very important. Okay, this is a slide I really love because we as individuals have to learn now that the field of prevention has been launched into cancer. We as individuals need to learn how to understand whether we are at increased risk for a hereditary cancer syndrome. Because these things have been going on through the ages and nobody knew. They knew that there's something in their family, but they didn't know what it was, they didn't know what it meant, and they didn't know what to do about it. Now we can do a lot. We can prevent a lot of these cancers. So what you're looking for when you're thinking about a hereditary cancer risk or a genetic mutation, you're looking for something that makes you realize that in your family there's different than the sporadic average population risk of cancer. You know, if somebody comes into the doctor and says, I'm worried that I'm at risk, high risk for colorectal cancer. Well, why are you worried? Because my grandfather got colon cancer when he was 86. That's unfortunate, but that is not a trigger for a high risk of genetic syndrome. These genetic mutations, many of them are associated with what's called high penetrance. They show up regularly in family members. So you would see a different pattern of cancer expression in a family that has a genetic mutation. For instance, a young age of diagnosis. You all know that people in their 80s, 70s, 90s can pop up with colon cancer. But when you have a family member who's had colon cancer in their 20s, their 30s, their 40s, that's distinctly unusual for colon cancer. And then you have to say to yourself, why do I have a family member with colon cancer at that age? Is it because there's something underlying in the genetics that predispose that person to a high risk of cancer at a time when most people don't get it? So some of the other things you have to think about that would make you think of these triggers, underlying genetic predisposition, are things like unusual cancers, male breast cancer in the family. Breast cancer, you know, is very common, but in men, it's not so common. It's not so unusual with some of these genetic mutations. Ovarian cancer, a rare cancer in the general population, but it has a significant association with some of the genetic mutations associated with colorectal cancer, pancreatic cancer, and some of the others. Multiple primary cancers in the same individual. So if someone gets cancer, we're upset, and it's very, it's very disturbing, and we say, oh, that's bad luck. But if you have someone, an individual, who gets one cancer, and then they get a different kind of cancer, that you have to think to yourself, gee, maybe that's not just bad luck. Maybe there's something underlying that person's genetic makeup that predisposes them to cancer in a way that the average person is not predisposed. And then family clusterings of certain cancers, multiple colorectal adenomas in a patient. When you hear in a patient or a family that there are tons of polyps, that's a red flag that there could be a mutation in that person or that family, predisposing them to a high risk of colon cancer, and then specific at-risk populations. Whoop, these disappeared. Okay. Now, these are the risks of getting colon cancer. The risk in the United States, for the men sitting out here, the men in the United States, each of you has a 1 in 21 chance lifetime risk of getting colorectal cancer. So 1 in 21 of you will get colorectal cancer, and 1 in 49 of you will die of that colorectal cancer, a preventable death. If you're a woman in the United States, then your risk is 1 in 22. 1 in 22 women will get colorectal cancer, and 1 in 54 will die of that cancer. Again, preventable deaths. If you have a family history, that does statistically increase your risk of getting colorectal cancer. If you have one affected family member, it statistically doubles your risk that you will get colorectal cancer. And if you have 2 or more, it at least triples your risk. So those are very important features of your family history to keep in mind. Okay, now, apart from a family history, there is this issue of a hereditary cancer syndrome and a genetic predisposition. And this is the population I was saying before, that we have to really move on and make sure that you identify yourselves, that your doctor pays attention, and that you get the proper attention, because you need a higher level of attention, and these lives can be saved. So Lynch syndrome, the one I was talking about, the mutation I was talking about before, if you have a mutation that causes Lynch syndrome, you have an 80% chance by the age of 70 that you will get colon cancer. You have a 60% chance, if you're a woman, of getting endometrial or uterine cancer, which is normally a rare cancer. And then on the bottom are the list of the other cancers that are also associated with Lynch, most of which can be prevented at this time. These are the polyposis syndromes, familial adenomatous polyposis and attenuated familial polyposis. Every study shows us that if you have one of these mutations, you have essentially a 100% chance you will get colon cancer by the age of 70. Those cancers, those deaths are preventable. And this is just a slide I wanted to put up because, you know, I'm a medical oncologist, so I see cancer patients often. I see patients who haven't had cancer who want to prevent it. But if you get a cancer, it's critical to find out if you have one of these syndromes. Because if you got the cancer because you have Lynch syndrome, for instance, from the time of that diagnosis of that first cancer, which we intend and hope to cure you of, you have a 50% chance within the next 15 years of getting another Lynch-associated cancer. If you know that you have Lynch syndrome and your doctor knows it, the two of you together can work to prevent those other cancers from occurring and certainly work to prevent death. So how do we do that? How do we get a hold of this and get it under control? You see someone who knows something about risk counseling, you educate yourself. You, as Dr. Gross said, you've got to make each individual tailor the prevention and screening to each individual's situation. And then remember, anything you learn that's related to family history or genetics, share it with all your family members, because that's how they're going to be protected as well. This is what the doctor has to focus on. This is the short list of what the doctor has to focus on when you come in to see what your risk is. The doctor has to do an expanded family tree to see what kinds of cancers exist, what age of diagnosis, what polyps there have been, what your personal medical history is, especially your own colon history, the age, the number, the type of polyps, the things we talked about, other medical conditions, and any exposure. And then focused exams, physical exams on things, as I say, that you might not know have any relationship to your risk of colorectal cancer. But they're very important because they can save your life. Some patients will be appropriate for genetic testing. Genetic testing is a complicated and multifactorial decision-making process that has to be done in concert with the patient and a doctor who understands how to do it and how to explain it. So then a decision has to be made in the end about the risk-benefit for each patient, the cost to each patient, and that's determined by, in large part, their level of risk. This is the American Cancer Society's guidelines for screening for people who have increased risk for family history only. So the key, the bottom line is at the top. The bottom line's at the top. If you have an increased risk because of family history, begin your screening early, before age 50, and screen more often. And these are the guidelines. You can see it's divided by whether your relative, your family history, is in someone under 60 or over 60, and how many relatives they are. And you get screened more often and at younger ages. Okay. If you have, look at this, if you have a Lynch syndrome, a hereditary predisposition, then all the screening that I told you about before is off. You have to be very rigorous in getting your screening. And if you do it, you will pick up the cancers early or before they ever form. So with Lynch syndrome, you have to start your colonoscopies at age 20 to 25, get them every 1 to 2 years, and yearly after the age of 40. You also have to screen for endometrial and ovarian cancer because those are preventable if you have that syndrome. And we do screening for bladder, prostate, and now there is data accumulating that we are beginning to get effective screening for pancreatic and thyroid and breast as well. For the polyposis syndromes, if you have a family that has a polyposis syndrome, then those children with that genetic mutation have to start their sigmoidoscopies annually at age 10 to 12. And that's because of the predilection of a familial polyposis syndrome, that cancer for the rectum. And then all of the polyposis syndromes those people need to be screened with colonoscopies and endoscopies. The colonoscopy should start in the late teens or early 20s, every 1 to 3 years, and endoscopy every 1 to 3 years, starting at the age of 20 to 25. Now, the management, once you determine whether you have a colorectal cancer risk, is lifestyle modification. Pay attention to that. It really does make a difference. And then either enhanced surveillance, the kind we've been talking about with screening, or surgical prevention, meaning a total colectomy, taking out the colon. Now, either of those approaches, the surgical prevention or the enhanced surveillance, either is acceptable and reasonable. The only thing that's not acceptable, the only thing that's not reasonable is not to do anything. Find out what your risk is and make sure that you're properly screened, because you will save your life. So that's what I want to end on. Just think about what we're saying. Remember that if you educate yourself, if you advocate for yourself, if you work with your doctor, it is never too late. Get your colonoscopies and get them even if there is no family history at all. Thank you.